Hello everybody, welcome to our couch conversation number 3. My name is Georg. I'm here in Freiburg, Germany on my couch, and on his couch in London, Ontario in Canada is my good friend Richard Rosedale.
Good morning everybody. Good morning Georg. How are you this morning?
How are you today?
I'm good, thank you. Good, yeah.
Okay, how's the weather in Canada?
It's a bit rainy here, but it's warmer, so maybe we've got spring coming early. We'll see.
Okay, crossing my fingers. So Richard, last time we talked about chronic pain and different aspects of chronic pain, biopsychosocial issues, and how we integrate it in our system and our educational process. So biopsychosocial issues, that's one aspect which might play an important role in the management of these patients. Another aspect might be that we as clinicians, we don't address the right body part. So, and we had this discussion before, and in 2019 we published the EXPO study, which was about maybe missing patients with a spinal involvement or with a positive reaction on spinal intervention. And now we published the indicators paper. So what's your take on missing the right body part when assessing these patients? Is that an issue, or is that part of the problem?
I think it's an issue, and I think it's one of those things where if you see something clinically that's kind of surprising and other people are seeing it, then that's the initial reason why we kind of wanted to study that and see if that could be verified in any way. But I just want to say, first of all, that I know some people have a concern of when we start talking about body part, we're putting patients in this kind of silo in terms of, okay, you're just focusing on this knee and sort of forgetting the human that's attached to it. And so my first question is, Georg, how often do you just think about the body part itself with your patients? Is that something that what happens in your daily clinic?
No, it's not happening at all, and hopefully it will never happen to me. So it's always the whole person that I'm talking to and assessing.
So I think that's an important point to make from the start. However, having said that, I think actually probably aligns with patient expectations in terms of you're trying to find or focus on where you feel their pain is coming from, rather than not. So if we're taking into account patient expectations, and I've got no data for this, but I'm assuming most patients would go into a conservative care clinician and expect them to at least look at and think about that body part. So in having said that, we kind of need to make sure we are treating the right body part for the best effect, I would think.
So do you think we have to screen every patient for a spinal involvement? So looking at the numbers from the EXPO study, with 48% of all shoulder issues having some relation to the spine or reacting positively on spinal treatment?
So I think there are a couple of things to think about here. So if we think historically maybe that, because looking at the literature, there isn't a great deal which emphasizes screening the spine, guides people in terms of screening the spine, and my feeling is most people do it in a fairly cursory way. So from that starting point, I think we are trying to encourage people to maybe consider the spine a little bit more. Maybe you need to be more thorough. And so we're trying to sort of, with the results of the research, we're trying to sort of bring that to light. But in doing so, obviously, we don't want people to go completely in the other direction where they're spending the rest of their lives treating people's spines and forgetting the possibility that in some joints, most problems are actually coming from the extremity and not coming from the spine. So of course there's a balance there. But initially with these studies coming out, I think we are trying to get people to move along that spectrum and try to think about the spine more with patients that present with seemingly isolated, very specific extremity pain that you would not necessarily have thought is coming from the spine.
Yeah, and that's especially what I like was the second paper we now published in January. the paper on the indicators for spinal involvement. So also I personally, I did hope that the first paper, the EXPO study, would also be seen as a pilot study for every clinician, not only McKenzie folks. But now we have the indicators paper, which from my perspective is even more suitable to be seen as a pilot study, as a starting point for other clinicians to have a look at this and maybe run research on this in their classification systems or in their non-classification systems. However, so non-MDT clinicians just trying to evaluate the idea of a spinal involvement in patients that are primarily presenting with or presenting primarily with extremity pain. So
that would be really neat to see.
That's a great potential.
Yeah, that would be neat to see if other people with other philosophies and approaches looked at this problem within their own sort of parameters, their own system, to try to figure out, okay, you know, are we getting sort of similar results here? We've put kind of one way forward of looking at this. It's in the context of a McKenzie kind of evaluation, but nearly all those factors are kind of conservative care clinician 101 in terms of assessment and aren't necessarily a McKenzie type assessment. So if we go through those factors, we have, you know, the presence of paresthesia in the history, these indicators that the problem may be coming from the spine. Presence of paresthesia in the history. We have information from the better worse section, aggravating easing factors section, if you like. You know, does bending affect the pain? Does, you know, sitting bring on the pain or make it worse? Does turning, like in the cervical spine, thoracic spine, or bending, as in terms of the lumbar spine, or just being still, do any of those things provoke the pain? Those kind of together as another indicator. So anyone could ask those. They only take a few seconds to ask for them.
Yeah, and also in the clinical exam, it's kind of a very basic physical therapy exam to look at movement loss of the spine and movement loss of the extremities, which you would of course you would check it.
Everyone does that, of course. It's the only thing is the posture change, which is up to this point kind of specific to a McKenzie exam. And you get your baseline, you change the posture, and then that extremity baseline, you know, you're rechecking that again and does that change. But like it takes about a minute to do. So I mean, anyone can integrate that into the exam, and then you have all the factors that you're considering, you know, might help you, guide you along in terms of your assessment, and answer the question of how much time do I really need to spend moving the spine around before I have ruled it out and can move on to the extremity. And if there are low indicators, then you know, you're not going to spend long moving the spine around if you don't see any change, and then move on to the extremities. If there are lots of indicators, then potentially it might be obvious, and they may change pretty quickly as soon as you move the spine around. But if they don't, you might be a little bit more thorough before you move on to the extremity.
So when we published the EXPO study 2.5 years ago, we had some criticism and some concerns about the study and some terms we used and everything, and some discussion was going on. Now with the second paper, actually it was quiet. It was somehow quiet, and not much discussion on social media. Not that many citations or references or whatever, and so I was a bit kind of disappointed on the one side, but also felt some relief on the other hand. So what do you think about that? Why is there not so much going on, not so much discussion on the indicators paper?
Yeah, you can take that two ways. I mean, you know, if you do get criticism on a paper, at least you know people have read it and paid attention to it. If you hear nothing, then, you know, one, people have either read it and thought, it's fantastic, I no need to criticize that, or secondly, they just don't think it's important, and they haven't read it or paid attention to it. So, and that's of course not a good thing, because as you said earlier, you know, this, you know, our feelings is this has implications for all clinicians, not just MDT clinicians, all clinicians, and
Yeah.
Be easy to integrate.
Also, it's in the title. It's not a McKenzie paper.
Yeah, that's right. I mean, we didn't even want to put McKenzie in the title at all. So to try and make it so other people would read it. So I don't know where this is going to go, but I would love to see other people take this on and kind of retest this out and explore this. You know, are the assumptions we've made about ruling out the spine, do they hold up in terms of, you know, when they've been explored research-wise? And it'll be great if other people looked at this as well. I think it's a really interesting area. It's something that clinicians do day in and day out. And so, but I think they make lots of assumptions. So anyway.
Sure. Yeah. Let's see how this goes and how many other clever people jump on this train and do research on this. Would be great.
Cleverer people, hopefully.
Yeah, hopefully. Okay. So Richard, have a great day.
Yeah, great speaking to you.
Okay. Bye.
Bye, everybody.
Bye, everybody.